Greetings. Let us talk about ascites management, especially the role of diuretics. Just want to thank many who support this program, and please read this notice. And coming to cirrhosis, in cirrhosis, ascites forms because of increased renin-angiotensin aldosterone system, uh, which results in retention of sodium and also water, and excess of fluid accumulation in the setting of portal hypertension results in ascites. And how do you manage ascites? You want to stop the retention of sodium and water by giving diuretics. So let us talk about which diuretics will be helpful in patients with cirrhosis. So let us go to the kidney. And as you know, this is the structure of a nephron, starting with the glomerulus and the tubule that goes from the cortex to the medulla. And important structures related to the nephron, glomerulus, proximal tubule, then loop of Henle, the ascending limb of the loop of Henle, where the sodium potassium chloride exchanger uh, plays a role, and then distal convoluted tubule, where aldosterone works and it retains sodium and excretes potassium and hydrogen. And this is where the aldosterone antagonists work. And in the ascending limb of the loop of Henle, the loop diuretics work. The classic example of aldosterone antagonist is spironolactone, and loop diuretic is furosemide. So when it comes to cirrhosis, ascites management and cirrhosis, it is predominantly due to secondary hyperaldosteronism. And unless you block that in the distal convoluted tubule, just giving furosemide will not be effective. So it's important to antagonize the effect of aldosterone in patients with cirrhosis. That's why you should start with spironolactone first, anywhere between 50 to 100 milligrams, and you could also add 40 milligrams of furosemide. So the patient is already on a salt restricted diet, less than 2 grams of sodium per day, and you start them on a combination of spironolactone and furosemide. This will be helpful to mobilize the fluid, and you monitor for a week to see whether the patient is losing weight. In the first week, the weight loss will be a little bit slow, but in the second week, it should increase. And if not, you can increase the dose of this combination diuretics of spironolactone and furosemide. Experts have already figured out how to use these medications in combination. And as you increase the dose of spironolactone, you also increase the dose of furosemide. 100 milligrams of spironolactone and 40 milligrams of furosemide to start with. Then 200 milligrams of spironolactone, and 80 milligrams of furosemide. And if there's no response, then you can increase to 300 milligrams of spironolactone and 120 milligrams of furosemide. And it's important to keep in mind the half-life of spironolactone is quite long, so you don't want to change the dose of the medication every few days. The spironolactone takes about 3 to 4 days to be effective, and so you want to change the dose probably not every day, but if necessary after a week or so, if the weight loss is not as expected. So important to go slow, and the initial phases it's also important to make sure that you're not pushing the patient to volume depletion and renal hypoperfusion, and renal injury. The maximum ceiling dose is 400 milligrams of spironolactone and 160 milligrams of furosemide. If at this dose the patient's ascites is not improving, despite the fact that the patient is in a salt-restricted diet, then you should be worried about the possibility of refractoriness setting in. This happens as the liver disease progresses. And once the patient's ascites starts resolving, you should also be on the lookout to cut down the dose of the medication and use the smallest possible dose. So we talked about spironolactone and furosemide. In cirrhosis, do not start with just furosemide because it's not going to be effective like the way the spironolactone works. As you can see, furosemide, even if it blocks in the ascending limb because of severe hyperaldosteronism, that is going to catch the fluid as it comes down the distal convoluted tubule, is not going to be very effective. So start with aldosterone antagonist, spironolactone, and then add furosemide, or you can start with a combination. So how do you monitor the patient? You should advise the patient about measuring their weight daily. It's very important. And you also explain to them about how the fluid exchange happens in the peritoneal cavity. And if you look at the abdomen and lining with peritoneal lining, that peritoneal membrane can exchange fluid to a maximum of 500 ml per day. So in patients without pedal edema, uh, if the weight loss is about 0.5 kilograms per day or 1 pound per day, that is a reasonable expectation. You don't want to push somebody without pedal edema with just ascites, losing a lot more weight than what is seen here, more than 1 pound per day. That is likely to cause volume contraction and potentially throw them into renal hypoperfusion and renal injury. On the other hand, if you have somebody with somebody with ascites as well as pedal edema, then you have a little more buffering capacity. And in those, even if you have a patient lose 1 kilogram per day or 2 pounds per day, still they're not going to get into trouble because the fluid in the legs is going to get reabsorbed a little bit faster and compensate for the volume that's lost. Overall, in ascites management, go slow as long as they're losing weight and you're going in the right direction. It's also important every time you see a patient in the clinic who is on diuretics make sure that you talk about sodium restriction to less than 2 grams per day, that is about 88 to 90 millimoles per day or milligrammes per day. And how do you monitor the impact of diuretic? One is you can check the weight. If they're losing weight, you know that it's working. That means they're compliant with the diet and the diuretics are working. On the other hand, if they're not losing weight, then you have to figure out, is this because the patient is not compliant with the diet and continues to eat high sodium diet, or the diuretic that you're giving is not sufficient, or the patient is resistant to that particular dose? And how do you figure out that? Traditionally, we have used 24-hour urine collection for sodium, and that is quite labor intensive for the patient, to collect urine for 24 hours without losing it is quite cumbersome. And if in case you go to that route, you should also measure the urinary creatinine. And there are values for cirrhotic men and women, how much of creatinine is thrown in the urine. And if it is less than that, you know that the collection is inadequate. So because of the inconvenience of collecting 24 urine for sodium, uh, people have come up with spot sodium slash potassium ratio. This is because when you add a diuretic, especially a spironolactone, which interferes with the aldosterone effect on the convoluted tubule, the sodium reabsorption is blocked. So sodium excretion increases, and potassium secretion is blocked. So potassium is retained. So what happens is there is more sodium in the urine and less potassium in the urine. And if the drug is active, you'll have a sodium by potassium ratio of more than 1. So in 24-hour urine collection, if your output is more than 90 millicoulombs per day or spot sodium ratio of more than 1, they're almost equal and they correlate very well. So a lot of physicians try to go for the convenience because you can still do a pretty good job if you just look for the urine spot sodium and potassium, which can be done very quickly instead of the laborsome 24-hour urine sodium collection. So how do we put these things together? You have a patient with ascites, and you you put the patient through dietary consultation. Patient is on a sodium restricted diet. You also started spironolactone and furosemide. You're monitoring the weight. And how do you know whether the patient is going in the right direction? And how do you make corrections? So let us look at a patient who is on sodium restriction and also on combination of diuretics, spironolactone and furosemide. And you ask the patient to bring their weight chart. And if they are losing weight, that indicates that whatever program you have set, it is working, and the patient is adherent to sodium restricted diet and is taking the diuretics as recommended. And in that case, you just continue the treatment, and if the ascites resolves, you can de-escalate therapy. On the other hand, you have a patient on therapy, dietary restriction of sodium and a combination of diuretics, and there is no weight loss, or the weight loss is not as you would want to see, then you want to figure out what is the problem. Is the problem because the patient is not compliant with sodium restricted diet, or is it because your diuretic dose is not sufficient, or the patient is refractory to a particular dose of diuretic? So, how do we go about doing that? So, you want to go back and check their kidney output of excretion of sodium. So, you do a spot a sodium and potassium ratio. And as we know, the spot sodium potassium ratio of more than 1 means that patient is excreting sodium well, more than 90 millicoulomb of sodium. Okay. So, so you have a spot sodium potassium ratio of more than 1. Patient is not losing weight. What does it mean? That means the kidney is excreting sodium as you would expect on a diuretic, but the patient is not losing weight. That means patient is not adherent to sodium restriction. The kidney is sensitive to the diuretic, but patient is putting in more sodium into the body instead of restricting the sodium. In that case, you send the patient back to the dietitian and counsel them about sodium restriction. So this is very important in clinical practice. You don't want to keep on increasing the diuretic dose. You need to go back to the basics, input versus output. On the other hand, if you have a patient with weight loss and their spot sodium potassium ratio is less than 1, that means that particular dose of diuretic that the patient is on, 100 milligrams of spironolactone, 40 milligrams of furosemide, that dose is not working. That is, there is resistance to that particular dose. And in that case, you still have room. You can go up to 400 milligrams of spironolactone and 160 milligrams of furosemide. You have a long way to go. So then you can increase the dose from 100 to 200 milligrams of spironolactone and 40 to 80 milligrams of furosemide. In other words, in this case, you want to increase the dose of diuretic. And this is how you manage patients with ascites. And once the patient is doing well, if the underlying disease is reversible, like alcoholic hepatitis and cirrhosis, and the patient stops drinking, or if the patient has HCV cirrhosis, you got rid of the HCV and the patient improves, then you de-escalate the therapy. So important to follow the principles of management. And when we talked about it, the dose increases, spironolactone and furosemide. While you're doing this, you're monitoring the impact of therapy. You also need to monitor if the patient is developing side effects. So periodically, you need to do labs to check the electrolytes and also kidney function with a BUN and creatinine. Because these diuretics can cause hyperkalemia, and if you just give furosemide without giving all spironolactone, they may develop severe hyponatremia. And as the cirrhosis worsens, patients can develop hyponatremia because of increased effect of the vasopressin on the kidneys. And when they get volume depleted and they're losing too much weight, and they can develop renal dysfunction. If that's the case, you hold off the diuretics. And spironolactone, you should always ask your patient whether they have any problems with gynecomastia. And if you have a patient getting a little bit confused and the family is worried about changes in the functional status of the patient, that means the patient is developing hepatic encephalopathy. Again, you have to withhold the diuretics in those cases. So, patient is doing well, everything is fine, then you don't have to worry. On the other hand, you have managed the patient, You escalated the dose of the diuretics. Patient is got severe ascites, coming back uh, without a good response, and maximize the doses. Patient is already on sodium restricted diet, and in that case, that means you are getting into what is called refractory ascites, and when that sets in, then pushing more diuretics would actually harm the patient. It can harm them by pushing them into renal dysfunction and hepatorenal syndrome. So, when you're getting into that, you may want to change course and consider paracentesis or large volume paracentesis. And we'll talk about it in the next video. Thank you. And I want to thank authors of this beautiful guideline. I've learned a lot reading this guideline, and this is the source for preparing this talk or this video. And I appreciate your time. Thank you.